Yeah, we are good to go.
So great. Thank you. Thanks for the invitation to speak this morning. And feel free to stop me in the middle and interrupt if you have any questions. My name is Jonathan Schoenfeld. I'm an associate professor of radiation oncology here at Harvard Medical School and attending physician at Brigham and Women's Dana-Farber here in Boston. And I specialize in the treatment of head and neck cancer, also treating skin cancer as well. Involved in some head and neck cancer research, also some immunotherapy research. And what I wanted to speak today is an interest that we've had in SBRT for head and neck, which is a little bit still less integrated here in Boston, I think throughout the world, in the treatment of head and neck cancers, but hopefully that's going to continue to change over time. And I wanted to focus mostly on the presentation and treatment of patients with locoregionally recurrent head and neck cancers, because as I'll go through, that remains a very pressing clinical issue for us, and it's really the realm where SBRT kind of has the most established role, at least now in 2019, although there's the potential for that to change in the future. So here are my disclosures. I do some research that's supported by pharmaceutical companies as well as consulting, and serve on some boards as well. I think this is probably well known to most people, but head and neck cancers remain a very important clinical problem. They're the 6th most frequent cancer worldwide. The most common histology remains squamous cell carcinoma, which develops from the cells lining the mouth, throat, and larynx. Historically, and still, worldwide, these cancers remain associated with tobacco and alcohol use in most cases. However, depending on where you're practicing, virally mediated cancers within the head and neck are becoming more common, particularly in the cases that we see here in Boston are HPV-mediated oropharynx cancers, but of course there's other virally mediated cancers that I'll speak about in a minute as well. We think about head and neck cancers in terms of the anatomic subsites that they involve, and we think about treatment and workup slightly differently depending on which subsite the cancer has originated from. So starting kind of from the top and working our way down, of course we have nasopharynx cancers, which are more common in other areas of the world, such as East Asia, and especially there, but also here in the United States. Most of the nasopharynx cancers we see are related to the Epstein-Barr virus, so EBV-related nasopharynx cancers. We also see nasal cavity and paranasal sinus cancers, salivary gland cancers, which can come in many different histologies. So they're the exception where squamous cell carcinomas are not the most common. Oropharynx, and again, most of the cases that we see these days are human papillomavirus related oropharynx cancers. Oral cavity cancers, larynx, hypopharynx, and then we see a fair number of cases where there's involvement of lymph nodes of the neck without a known primary source or an unknown primary squamous cell carcinomas of the head and neck. And just looking at the anatomy, you can see how we divide up the head and neck into these various different subsites, which of course has ramifications for both initial treatment and then how we think about recurrences as well. So local regional recurrence in head and neck is cancers are a big problem. If you look at the large meta-analysis of 80 trials called the MOC-NC meta-analysis that was published back in 2011, the 5-year local regional recurrence rate was as high as 60%, somewhere around 50 to 60% of patients, which accounts for over 13,000 patients a year. And contrast that to the rate of distant metastases, which is less than 20%. So in contrast to many other different types of cancers, really historically, the predominant location of failure for head and neck cancer patients, those who do fail, is actually local regionally, so either in the primary site that was treated or in the lymph nodes of the neck or somewhere, close by. This data has been confirmed in multiple other studies. So there is a more recent analysis of RTOG trials that was published in the JCO in 2014 that demonstrates that 55% of failures in this study were isolated local regional recurrences, so local regional disease in the absence of distant metastatic failure. There's also been a question of, okay, now that the biology has changed of these cancers that we're seeing in many cases because of the favorable prognosis of the HPV-related oropharynx cancers, have the distribution of failures changed? And there's been a couple of studies that have tried to look at this. This is a recent study that was out of the Prince Margaret Hospital looking at their cohort of patients that was published in Head and Neck last year, and really dividing it out between HPV negative and HPV positive recurrences and looking to see where these failures were. Were they located, were they within the neck, and were they distant, or were they distant? And this is a relatively modest sized study, especially compared with some of the other analyses that I mentioned on the last two slides, but still over 100 patients, over 120 patients. And when you look at the HPV negative recurrences, you see patterns of failure consistent with the historical literature. So predominantly at the primary site, which accounted for 62% of failures, or within the neck, 28% of failures, as opposed to the less common isolated distant failures, which if you look at the Venn diagram was really only about 22% of patients. If you look at the bottom of the slide, though, the interesting and I think new piece of data that's beginning to emerge is, there's the thought that the HPV-related cancers are more locally responsive, and so maybe the failure rate, the patterns of failure are different and predominantly distant. And there is a little bit of a difference, I think, compared to the HPV negative recurrences, but still, if you look at the patterns of failure, you see 44% primary, 29% within the neck, and only an isolated distant failure rate of about 35%. So even in the era of HPV-associated disease, even in EBV positive nasopharynx cancer, pretty much across the board, local recurrence, local regional recurrence remains an important clinical issue. So some of the other reasons why locally recurrent head and neck cancer is a very important clinical problem is these recurrences can be significantly morbid. These patients can present with quite significant amounts of pain, swallowing issues, they're height dependent. As the tumors, recurrent sites are impinging upon the airway, there can be breathing issues requiring a tracheostomy. These patients have often limited treatment options, both because they've often had extensive prior therapy, not uncommonly having had surgery, radiation, chemotherapy. Also, these patients have often limited performance status, which affects their ability to tolerate intensive treatment. So how do we think about management for these patients? So when we see a local regional recurrent head and neck cancer, this is a cancer that had been treated at some point in the past, we generally favor surgical resection whenever possible. Just given the prior treatments, it's often hard to recommend any other potentially curative treatment, although I'll talk about some potential alternatives, especially as it applies to radiation, especially in regards to radiation SBRT. Unfortunately, however, in the literature, only about 50% of the local regional recurrences that people present with are potentially surgically salvageable. And that's for a variety of different reasons. So again, these patients are often fairly sick, so comorbidities might include surgical resection. The extent of disease that patients present with may also make it not possible to even attempt a complete resection. And again, we don't generally think about debulking these cancers. We would only recommend surgery if we could, if the surgeon thought that they could remove all of the the recurrent disease with the negative margin. And then many of these patients have already been through quite a great deal in terms of prior head and neck cancer treatment. And so, it's their preference actually not to proceed with another surgery. So what are the other options? Well, for the sake of completeness, I'll talk about all of them, at least briefly. Obviously, I'll spend the most time talking about re-irradiation and particularly focus on re-irradiation with SBRT. Also, I wanted to cover systemic treatment and palliative care somewhat. So again, what are the considerations for surgery? Because these patients should be considered for surgery, I think, if possible, if that's something that's available. It's the disease extent, so we want to make sure that there's the ability to achieve a complete resection in the surgeon's estimation and the recommendation of the treating providers. And then the patient, of course, has to be able to tolerate surgery and also has to have the expectation for a reasonably good quality of life following surgery. In some cases, the extent of the recurrent disease is involving the structures that are critical to speaking and swallowing, to the point where a really extensive resection with the goal of achieving negative margins is thought to really not be conducive to a favorable quality of life, and in that case, that wouldn't be our typical recommendation. So it ends up that surgery is the most viable for kind of these early stage recurrences, T1, T2 recurrences, certainly 2-3 centimeters. Once you start getting much beyond that, it becomes more difficult in most areas of the head and neck for most people. And it does produce some favorable results. So, this is an unfavorable situation to start with recurrent cancers. And in the meta-analysis that was published in Laryngoscope back in 2000, in patients with locoregional recurrences who are able to undergo surgery, you do have some long-term responders that approach 40%. And I'll talk more about some of this outcomes data in a minute. The question then becomes, what do we do after surgery? So now I'm talking about the small subgroup of patients that has a local recurrence and that is able to go for surgical resection. These surgical resections, even when they're feasible, are often technically challenging. Margins are often close or potentially even positive. And so we're left with a little bit of a clinical conundrum. Do we do anything else after surgery? And really the two the two options that are considered most commonly are, do we observe or do we consider re-irradiation at that point? I will just say there have been studies that have evaluated the potential benefit of systemic therapy in this setting, and systemic therapy in the absence of residual gross disease following surgical resection of a recurrent malignancy has not demonstrated benefit in reducing the risk of recurrence, so we don't generally do that. So what's the data? So when looking at re-irradiation following surgery, I wanted to talk about a few trials. First is the GETTEC GORTEC trial, which in this setting compared surgery alone, compared against surgery followed by chemoradiation. Now, the regimen that was given is not a typical regimen that we currently use today, at least in our practice. It was 10 gray delivered in 5 fractions, administered with hydroxyurea and 5-FU. This was repeated for 6 cycles with a 9-day rest in between cycles. There were 130 patients accrued to this study between 1999 and 2005 in centers in France and Belgium. These patients were high-risk patients, so 84% had lymph node involvement, 49% with ECE, positive margins or more than 1 involved lymph node. And the treatment field was defined as the surgical bed plus about 1 to 2 centimeters, as well as the first adjacent nodal area. And the results of the study was that radiation improved locoregional control pretty significantly with a hazard ratio of 4.5, as well as disease-free survival. However, there was no improvement in overall survival, and there were more treatment-related deaths, distant metastases, as well as second primary cancers in the patients who received re-irradiation. So here is the data. Again, as you can see on the left, following surgery, chemo re-irradiation was associated with a significant benefit in terms of locoregional control. However, there was no benefit seen in overall survival. So at least based on this study, the general practice of offering re-irradiation with chemotherapy following surgery, just due to the side effects, didn't really make it into generalized practice because, even though you benefit locoregional control, there was no benefit to overall survival. There have subsequently been multiple retrospective studies that have looked at the potential role of radiation following surgery. Of course, these are lower levels of evidence. They're not randomized. There's a lot of heterogeneity in terms of the patients that were enrolled on these studies, their surgical status in terms of what were the indications for radiation following surgery, also the regimens that were used, what dose. Was it twice a day? Was it once a day? Mostly these are older studies, so the techniques were not modern IMRT or conformal radiation, which I'll talk more about. So that's a limitation as well. There was kind of heterogeneity in terms of chemotherapy. But all that being said, I just wanted to focus on the 2-year outcomes. You do see some relatively favorable results, although there's a lot of heterogeneity, as you might expect from the parameters. With local regional control rates and overall survival rates at 2 years, that range actually, upwards of 50%, 70% in some studies. So it does seem like in a particularly well-selected group, you can achieve favorable results with the combination of surgery followed by re-irradiation, potentially with the addition of chemotherapy as well. So to summarize the surgical-based approaches, we actually, in our practice, we consider re-irradiation following surgery for appropriate candidates. With the caveat that the data suggests that radiation improves local control and disease-free survival, with no proven benefit on overall survival. So we generally limit this to the really high-risk patient populations, such as those with positive margins or extracapsular extension, where we're very worried without any additional treatment, these patients will have a further locoregional recurrence that will probably not be salvageable. I will just say, because I'm going to spend a lot of the time talking about SBRT, that I really don't think, at least right now, there's a role for SBRT in this setting. That makes sense because, SBRT obviously works when you have a well-defined target. And so even though we want to be very conformal because this is re-irradiation, because this is mostly post-surgical treatment, the treatment fields need to be a little bit larger. And so while we have been exploring some approaches where we would either do hypofractionated, so like a shorter course, or a SBRT-like boost in some of these patients, particularly to the areas of positive margins, we're really doing that as much more of a research study. And our standard for these patients, when we do offer them re-irradiation, is conventional IMRT radiation, just like we would do a post-operative patient in the definitive setting. I do think well-selected patients, in our experience, do have a chance at a long-term survival with surgery followed by re-irradiation, as high as 40 to 50%, or like I said in those retrospective studies, even potentially higher. The toxicity is significant, and that's a theme that'll come up with all of these re-irradiation treatments. In the studies that I mentioned on the previous page, there's as high as an 8% fatality rate associated with this aggressive treatment for these recurrences. There's also a significant rate of about 33% in terms of grade 3 to 4 toxicities as well. So that's all I'm going to say about initial surgical approaches. I'm going to spend the rest of the lecture today talking about the cases where there are unresectable local regional recurrences, because unfortunately this is something we see quite commonly. I will just say that worldwide there's a tremendous variation in treatment practice for this group of individuals. Some places consider these patients purely palliative, and so do not consider local approaches such as radiotherapy, even for a localized recurrence following initial definitive therapy. The regimens that are most often used in centers that kind of go this route historically have been chemotherapy approaches. In Europe and the United States, predominantly until very recently, favorable performance status patients receive the extreme chemotherapy regimen due to data I'll talk about on the subsequent slides, and so that was the first line of treatment. More recently, however, and this is just a very recent update after the ASCO meeting in Chicago this year, earlier in 2019, with the presentation of the Keynote 48 study, immunotherapy with the PD-1 inhibitor pembrolizumab, where the combination of pembrolizumab and chemotherapy was shown to be superior to chemotherapy alone, and it was subsequently FDA approved here in the United States and is now an acceptable first-line treatment option for patients with either metastatic or local regionally recurrent head and neck cancer. And this has been rapidly adopted because of the favorable side effect profile of immunotherapy. I will say that now, in our practice at least, most of these patients who are not candidates for local therapy are receiving immunotherapy in some form, either immunotherapy monotherapy or immunotherapy plus chemotherapy as their first option. But I do think that well-selected patients, certainly in our practice and in many other high-volume head and neck centers as well, can be considered for re-irradiation-based approaches. And there can be significant variability depending on the recurrence and the patient, but generally the spectrum that we consider for these patients when we're thinking about local re-irradiation options is palliative radiation, so a lower dose treatment aimed at really reducing symptoms, conventionally fractionated radiation or even chemoradiation, and for this we generally use intensity modulated radiation therapy, and I'll talk about some of the data that supports this. Or increasingly we're considering SBRT or stereotactic body radiotherapy for some of these patients. So again, I wanted to start by kind of talking about the data, particularly the prospective data. There's unfortunately very limited randomized data. There is this older GORTEC study that randomized 57 patients with unresectable local recurrences from 1999 to 2005. The comparison that was made in the study was either weekly methotrexate, so a chemotherapy-only treatment, and this was compared to a chemoradiation treatment paradigm where patients received 6 cycles of 10 gray over the course of 1 week, so 10 gray per week, in combination with hydroxyurea and 5-FU in kind of a week on, week off schedule. And the radiation was delivered to the gross tumor volume plus at least 2 centimeters, and again, the adjacent nodal level, kind of similar to the previous study that I talked about. In terms of outcomes, 4 complete responses were achieved with radiation, none with chemotherapy alone. There were, not surprisingly, more treatment-related deaths and grade 3 to 4 toxicities in the arm that received the re-irradiation therapy. And unfortunately, this small study that was kind of underpowered demonstrated no difference in overall survival between the 2 arms. So both arms had an overall survival of 22 to 23% at 1 year. So there were several issues with this trial. The arms were somewhat imbalanced despite the randomization, with more locally advanced tumors in the radiation arm. This, like I said, was a underpowered study. Unfortunately, patients and practitioners had trouble randomizing patients And so there was actually planned to enroll 160 patients, but only approved 57. And again, this was an older study that used older radiation techniques, fractionation, and less common chemotherapy regimens that we use today. And so, there was an attempt to conduct a more modern study using updated radiation techniques and chemo and dose. Unfortunately, this study also had significant trouble accruing. This was RTOG 0421, which tried to use cisplatin and fractionated radiation. However, this study had to close because it was unable to accrue. So that's unfortunately the only randomized data that I'm aware of. There's also prospective data. There's RTOG 9610, which enrolled a larger cohort of 86 patients between 1996 and 1999. Again, they used a regimen that with a 1-week break in the middle. They used a BID regimen, 1.5 gray BID for 4 weeks, with a total dose of 60 gray. The radiation target was the gross disease plus at least a 2-centimeter margin. Again, this was before the IMRT was used, and the chemotherapy was still hydroxyurea and 5-FU. They demonstrated a 15% overall survival at 2 years, only 4% at 5 years. But again, there was significant treatment-related toxicity in this study, where there were 8% acute treatment-related deaths, 70% feeding tube at the time of last follow-up, as well as 22% late grade 3 to 4 toxicity. Another prospective trial was RTOG 9911. This enrolled 105 patients from 2000 to 2003. The dose that was given was 1.5 gray BID again for 4 weeks to a total dose of 60 gray with a 1-week break. It was the same targeting of gross disease plus 2-centimeter margin. A little bit more common chemotherapy regimens, so cisplatin and paclitaxel. A little bit more favorable outcomes, 26% overall survival at 2 years. However, there remained significant toxicity with 8% treatment-related deaths and 34% late-grade 3 to 4 toxicity. There was also more recently, I think just last year, an interesting study that was a multicenter phase 2 study. And the interesting part about this study was they were able to incorporate more modern radiation treatment, so re-irradiation with intensity modulated radiation treatment. And they also used a more modern chemotherapy regimen, such as cisplatin and cetuximab. The GTV was treated to 60 to 66 gray and 30 fractions. The brainstem was limited to 60 gray, and the spinal cord was limited to 54 gray, and they actually saw much more favorable results. Of course, it's hard to directly compare because this is a study that was conducted almost a decade later or 2 decades later than the other studies, so staging and other aspects of treatment were probably better as well. But encouraging to see that the 1-year overall survival was 60% and progression-free survival was 34%. So there's also significant number of retrospective studies that have looked at unresectable cancers and conventional radiation. So again, this is an older group of studies looking at patients that received re-irradiation before the IMRT era. I wanted to again, I just mentioned that there's significant heterogeneity in these studies, and if you look at the outcomes at 2 years, you can see they're really all over the place, anywhere from overall survival from as low as 5% to as high as 60 to 90%, depending on the study that you look at. So it really depends a lot, I think, on the patient population. Here's some more data. Again, significant amounts of heterogeneity within the previous retrospective studies that were done with conventional radiation. And again, just more studies. So a lot of different experiences. I think the interest more recently, of course, has been, can we improve outcomes with intensity modulated radiation therapy? And I think if you look now at a larger number of retrospective studies, including a couple from our own center here in Boston, you do see that with the use of IMRT, when you look at 2-year outcomes, because of more sophisticated targeting and ability to take the gross disease to a likely higher dose, you are starting to see more of these studies demonstrating overall survival and local regional control upwards of 20 to 30, 40, some cases even 50%. So there were some studies that did show this in the conventional radiation era, but I think more consistently in the IMRT study, in the IMRT era, you're seeing patients that are able to demonstrate local control following re-irradiation. Here's just some more examples of retrospective studies using IMRT. So to summarize, if you look at these retrospective radiation studies in the case of unresectable disease, you see widely variable rates of disease-free overall survival. Unfortunately, long-term survival are rare. I am going to talk a little bit more about the significant rates of severe toxicity, which I kind of didn't spend a lot of time on previously, especially because that's one of the big reasons why we think about SBRT, or we're starting to think more about SBRT in these patients. And this includes significant rates of long-term toxicity and treatment-related deaths. And then it's really hard to evaluate the impact of surgery, systemic therapy, due to patient heterogeneity as well as selection bias for some of these experiences. So if you're going to really compare, this was a nice attempt that was made in a previous publication back in 2013 to look at, how do we counsel patients, what do the retrospective studies generally show. You can see that untreated, you really don't have any long-term survivors. The median survival is just a few months in most cases. Patients who have salvage surgery and then adjuvant treatment, potentially in high-risk patients, demonstrate 5-year overall survival somewhere between 20 and 40%. With re-irradiation, with or without systemic treatment, the numbers are dramatically lower, so there are 5-year survivals, but in this kind of review, it was only 4%. I think that's probably an underestimate. We certainly see a higher than 4% of patients who are able to achieve kind of prolonged disease-free intervals, but certainly there's a lot of heterogeneity and a lot of skepticism, and that's why we need to investigate new approaches specifically for this population of patients. And then with systemic treatment alone, 5-year overall survival is very low, just over 1%. That may eventually change now with the approval of immunotherapy in that space, in this space where you can have some long-term responders, but the data from that are still not mature. So I did just want to spend just another minute on systemic treatment. Historically, patients with locoregional disease not amenable to local treatment were grouped with patients with metastatic disease for head and neck cancer. Outcomes were poor, with few or no long-term survivors. I mentioned the extreme regimen before. This is a combination of a platinum agent as well as 5-FU and cetuximab. And this demonstrated an improvement in median survival to over 10 months. Keynote 48, which is the study I mentioned before that was presented at ASCO this year, demonstrated very promising results with immunotherapy, with pembrolizumab, with chemotherapy, pembrolizumab combinations, which are now, probably superior to extreme in the majority of patients that we see with recurrent cancers or metastatic cancers. And then, these patients often ask, well, what if I do nothing? Especially given all that they've already been through. And with palliative care alone, median overall survival is relatively short, about 100 days. I mean, I definitely think this is the right choice for a subgroup of patients that can't tolerate more aggressive therapy, even if they just have locoregional disease alone. But again, it's just kind of helpful to counsel patients that oftentimes we even try local therapy because it does have a palliative benefit and because the survival is so short without any therapy. So how do we select these patients? So we're getting better at figuring out some of the prognostic factors for patients with locoregional disease. Of course, patient factors are very important. So what are the comorbidities? Can they tolerate more treatment? These patients do better with social support? Do they have family that can help them get through treatment? What's their performance status? Have they been losing significant amounts of weight? And do they continue to use tobacco and alcohol despite the fact that the cancers are often related to these factors? In terms of disease factors, the stage of recurrence obviously influences the potential treatment options, as well as the disease-free interval from their prior therapy. So, have these patients recurred within a few months of their initial treatment, or has it been years? A non-larynx site of recurrence is unfavorable, so that starts to get into more detail about the specific larynx. But of course, a larynx recurrence following chemoradiation is often salvageable by a total laryngectomy, so a big surgery. And so, those patients can be salvaged a little bit more easily than some of the other sites of recurrence. Patients who've received previous chemotherapy then are a little bit more refractory to systemic therapy, so they generally have a worse outcome. And then among the worst outcomes that we see are patients actually with metastases that have invaded the skin. For whatever reason, these patients are often relatively refractory to additional treatment. There's actually been a lot of effort recently to better characterize these patients in terms of what is their prognosis, to help select them for different treatment approaches, such as SBRT. This is a study that was published in the Radiation Oncology Red Journal last year, and was a multi-institutional collaborative study, actually a series of studies. And as part of this study, this group of institutions did a recursive partitioning analysis among patients with locally recurrent head and neck cancer and looked at what were the predictors of outcome. And so as you can see on the left, the biggest predictor of outcome was the time from their initial treatment. So patients who had more than 2 years from their initial treatment before they developed recurrence had more favorable outcomes. This was especially true if these recurrences were able to be resected, so that's kind of in line with the other data that I presented before. And so if you have a prolonged recurrence after 2 years that's able to be resected, you fall into this class 1 bucket with a 2-year overall survival of upwards of 60%, and you can see that reflected in the overall survival curve on the right. On the flip side of things, if you have a short interval recurrence, less than 2 years, if you present with organ dysfunction, then you get binned into this class 3, where your 2-year overall survival is only about 17%. So again, still better outcomes than you see historically in some of these other retrospective studies, but there is a lot of variability based on some of these prognostic factors, and that can help us guide treatment recommendations. Should these patients be considered for systemic treatment only? Should they get more definitive IMRT with chemotherapy? Or should they be considered for a shorter course SBRT approach? Again, here's additional data from this multi-institutional collaborative study. This is stratified by whether or not patients underwent post-operative radiation therapy, so that was offered to a significant number of patients in this collaborative, so almost 200 patients did receive post-operative radiation versus definitive treatment, and you can see survival was more favorable with the post-operative treatment, compared to definitive re-irradiation, so not a surprise based on the other data that I showed. Okay, so toxicity. I did want to focus on this because this is one of the big reasons why I think we're considering SBRT on more of our patients. It's not so much the acute toxicity. Certainly patients can have acute toxicity. They're still getting radiation to the head and neck, but it's often comparable to the initial radiation treatment, but sometimes it's actually even more easily tolerated because the radiation dose is less in the recurrent setting sometimes, and elective treatment volumes are reduced or eliminated, which is our standard. But the significant concern is late toxicity. So we see really late toxicity rates as high as 30 to 50%. Really depends on how long you follow these patients and how carefully you look. The specific concerns that we have are these patients have high rates of osteonecrosis, the mandible, the cartilage. There's a not insignificant risk of potentially fatal carotid blowout. these patients are at significant risk of permanent tracheostomy or PEG dependence. And that's really in contrast to some of our patients who are getting radiation and chemotherapy that have been previously untreated. If you try to quantify some of those risks, for carotid risks, historically in the literature we see about a 3 to 10% risk. When this happens, it's a median of 8 months after re-irradiation, and unfortunately, and not surprisingly, it is a high fatality rate that's associated with carotid blowout, as high as 75%. More meaningful, I think, for the majority of patients is the permanent effects on their quality of life with standard re-irradiation. I think this is probably underreported in much of the literature and also underestimated because of these high competing risks for these patients of recurrence and death due to disease. But in our long-term responders, we actually saw a PEG dependence rate of greater than 50%. So that really patients do have to be counseled about the significant long-term risks with standard re-irradiation strategies before they kind of embark on a treatment that can really permanently impact their quality of life. Here is the data from a multi-institutional collaborative study that was published. Again, you can see that there are certainly acute toxicities, including acute grade 5 toxicities that patients suffer when they undergo re-irradiation. And then if you look at late events, you see that it's late toxicity is upwards of 14% in this study. So what do we do about this? So in terms of trying to reduce late toxicity rates, they tend to be decreased with more conformal treatments. For example, IMRT. We try to deliver less elective treatment, and so we standardly don't give elective treatment. We just focus on the gross disease. We use conservative dose constraints, so we limit, for example, the spinal cord and the optics to less than 12 gray, and then again we have to carefully select these patients and counsel them about these long-term effects. I will say that the significant rates of long-term toxicities have prompted an interest in more targeted treatment, for example, SBRT, and so that's what I wanted to spend most of the rest of the talk speaking about. So before I talk about kind of our practice in SBRT planning, I wanted to start out by looking at SBRT outcomes. Again, this is the retrospective review. So this is the review that looked at all the retrospective studies that had been published evaluating SBRT. These studies, there are fewer of the SBRT studies than there are the IMRT or the conformal radiation studies. However, there's starting to be more of these reports from high-volume head and neck centers that have been published. There's still, we're still learning about the best way to deliver head and neck SBRT. So you can see that when you look at the different studies that have been published, there's a lot of heterogeneity in terms of the doses that have been used. Generally, they start either, less commonly it's a single fraction treatment, although you can see there have been some experiences that have published on a single fraction of 16 or 18 gray. Much more commonly, it's a more fractionated treatment. 30 gray and 3 to 5 fractions on the lower side, and on the higher side, hyperfractionated treatment up to as much as about 44 or 45 gray. Generally, this is not given in combination with chemotherapy or systemic therapy, although there are some studies and experiences that have evaluated SBRT with rituximab or more recently immunotherapy. If you look at the outcomes, again, it probably has to do a lot with patient selection in these early reports. So if you select the less favorable group of patients with early follow-up at 2 years, you have overall survival that's very limited. If you select the patients to be a little bit more favorable, you can have overall survival that exceeds 50%. And the most intriguing, I think, piece of data to emerge from these initial studies, but again, it's still very early, is the late toxicity rates, which can be quite limited. So, grade 3 to 4 toxicities, you do see, but in some of these studies, especially the more recent ones, the rates are actually look a little bit lower than some of the conventional re-irradiation. So here's the data from the multi-institutional collaborative study, where they are seeing institutions that are starting to use more SBRT, and you can see on multi